Hey guys, this is Charity Stanley, and today we're talking about burns. So, nursing interventions for burns are quite intensive. Burns are very, depending on the thickness, life-threatening, and it's also vital that we are able to help the patient's other body systems be able to recover their function that has been damaged, slowed, or stopped as a result of the burn. Burn injuries usually happen at home, and it's something that requires a lot of medical attention for. Young people and older adults tend to be at higher risk for burns. Young kids, because they often will reach out and grab pots that are on the stove. Older adults, their sensorium starts to slow down and they aren't as likely to feel the heat injury, so they keep in contact with the burning source for a longer period of time, or they are immobile and unable to escape the burn. So, nurses play a key role in helping to prevent future burns through legislative change and through health promotion concepts. So, with this is a person's back, a gentleman's back, and the back of his head. So as you can see, he has several burns that have escarred over. So it is you can't stage how far the burn is since the escar is covering it. So depending upon the severity and the amount of tissue that's burned, depends on what needs to happen to help this patient. So severe burns create systemic problems and it creates hypovolemic shock that we've talked about in the previous shock lectures. So this is a form of distributive shock. And what happens within the burn is that plasma will leach out from the bloodstream and that decreases the blood volume. So we can have full on hypovolemic shock secondary to burns. Depending on where the burn is, you may also have to watch your airway. Often you'll see patients with singed nares, singed nasal hairs, singed eyebrows, etc. And I've also seen patients who were on oxygen, who were on a nasal cannula, who actually were smoking at the same time that the oxygen was on. And the oxygen is actually very flammable and can catch fire. So it's important that you educate your patients when they're on oxygen that it is not a good idea to smoke while the oxygen is on, and you shouldn't have the oxygen turned on anywhere near there is an open flame. So classification of burns, this is going to be first degree, second degree, third degree, and fourth degree burns. So first degree burns is going to be the skin itself is burned. We've all had first degree burns. This is going to be something like a sunburn. And we also could have second degree burns as a result of a sunburn. This is going to be more like a blistering burn. So, what a burn is something that damages the integrity of the skin and the coverings of the body, whether that be mucous membranes with the mouth and the nose, any kind of openings, or any kind of area that's covered with skin. Okay, so first degree damages the outermost layer of skin. Second degree damages the epidermis and parts of the dermis, and this is what creates the blisters. Now, first degree burns are very painful because the skin is injured itself. Second degree burns are very painful as well because your nerves are still intact with second degree burns. Third degree burns, these are full thickness burns. And so with third degree burns, they can be painful, but likely they are not painful because you have already burned all the neurons that send pain signals. So you may have a full lack of sensation with third degree burns. Fourth degree burns involves deep tissue, muscle, and bones. Often with a fourth degree burn, there's not much we can do for rehabilitation for it. It's something that's going to have to be amputated or removed. So first degree burns. A first degree burn, you can see is just the epidermis. And so it's reddened, but it still blanches. There really isn't much swelling. Second degree burns, you start to see swelling. And first degree burns, no blisters. So this is going to be somebody who has been sunburned, scalded, burned by steam, pouring out the water from the spaghetti noodles. That's a very common way that people get first degree steam exposure burns. So with this patient, they need to consume large amounts of fluid to help replace the fluid that they have lost from drying out the skin. A second degree burn. This is where the epidermis and the dermis is burned. This is going to be a patient that has red mottling to the base of the burn. It may or it may not blanch to pressure. So if it's a deeper burn, it will not blanch to pressure. And this tends to be scalds, a flash flame, or even a severe blistering sunburn. This is the kind of patients that you will be getting with sun poisoning. So dependent upon the amount of tissue that's burned and the severity, this may or may not require skin grafting. So as you can see from the second degree burn box in the lower right hand corner of your screen, you can see the epidermis is damaged and part of the dermis is damaged as well. So this actually is involving the nerves. So depending upon if the nerves are burned will depend upon if the patient has feeling in that area. Then finally, we have a third degree burn. A third degree burn, the entire thickness of the skin has been burned, and these third degree burns are likely not painful because you have already burned up the nerve endings. So third degree burns often appear very leathery, very pale white, or it can appear completely charred. So you may see blood vessels that have coagulated, and you're going to see severe swelling. So with a third degree burn, this skin cannot heal on its own. It has to be replaced to be able to create a safe area for that skin to grow up under. Now, it may require multiple skin grafts depending upon uh, how large the burn area is. Now, burns can happen due to temperature, can happen due to radiation, like a sunburn. It can happen as a result of chemicals. You could have a chemical burn. And you can also have a third degree burn that's a result of an electric current. Now, if it's an electric current burn, we have two different mechanisms. This is going to depend on, is it AC current or is it DC current? With electrical current burns, your heart will often be involved because your heart is electrical as well. So AC burns, alternating current, is likely to put your patient into VTAC, VFib, whereas DC, direct current, puts your patient into asystole. Okay, so depending upon the type of electric current, the consequences may be different. Fourth degree burn. This always involves deep, deep tissue, muscle, and bone. So as you can see, these fingers have been completely charred, and as a result of them being completely charred, these aren't going to be able to heal themselves. So it's likely that these fingers will have to be amputated, that there's too much tissue gone, that grafting will not be of any benefit. So this is due to prolonged exposure, or if you are working on high voltage electrical devices such as if you're a lineman and you're working on the transformers. What can happen is once you start receiving an electrical shock, it causes the tissues to spasm and to hold you on to that high voltage source. And so that causes significant burn injuries. Several different factors are involved in figuring out exactly how deep the burn is. You need to figure out what caused the burn. You need to figure out the temperature. Was it boiling water or was it just hot water from the bathtub? The amount of time that it was in contact with the skin and the thickness of the skin at the site of the injury. So the thicker that your skin is, the less likely you are to experience a severe burn. So there's several different methods that we can use to estimate the total body surface area burned. So with this, um, the one you're going to see most commonly is going to be the rule of nines. Okay. So you will need to know how to calculate the rule of nines. If we give you a question with like patient's chest is burned, abdominal region not burned, it's only on the front, not the back. If we give you a patient scenario, you need to be able to figure out the rule of nines and be able to give us a percentage for that. So this is based upon anatomic regions. It's really simple. You just have to memorize how much value is for each part of the body. So there's a couple of other ways. One is using the Palmer method. So this is based upon the size of the patient's hand, fingers included, is 1% total body surface area. Okay, that's the Palmer method. And then the London Browder method recognizes percentage of total burned surface area based upon different body parts. So there's a rule of nine for adults, there's a rule of nine for babies. Now, with this rule of nine on an adult, the chest, the top part of the chest, is 9%. The bottom part of the chest, the abdominal area, that is 9%. And the upper back is 9%. The lower back is 9%. But you can look at it as a total 18% for the front, 18% for the back. So for the arms, it's 9% for each arm. If only the front of the arm is burned, then that would be 4.5%. If it goes all the way around, then that would be 9%. So the same thing for the legs, 18%, depending upon the area that's burned. And if the genitals are burned, then that is equivalent to 1%. So we will be asking you the rule of nines about an adult patient. So I need you to know that information. However, you also need to know that there's a uh, different percentages for babies because their heads tend to be larger than adult heads. And so as a result of that, burns are more likely to involve the head. So a sample question. You've got a nurse admitting a client who has had severe burn injuries in a grease fire. The nurse shades the diagram indicating the burned surface areas. Using the rule of nine, what percentage of the body, the surface area, has been burned? Okay, so we have the front of the chest, that's 18%. Okay, and then the back is not burned, so we're still only at 18%. So on that left arm has been burned completely. Okay. And so we would add 9% to that. That takes us to 27%. And then half of the patient's right arm has been burned. So that goes 4.5%, taking our total body surface area burned to 31.5%. What happens when a patient has a major burn injury? First off, there's going to be major fluid and electrolyte shifts. I talked about that plasma will leach out from the burn. And so with this, our patient may develop hypovolemic shock. Depending on the type of burn, there may be cardiovascular injury. There may be lung injury if it's due to an inhalation burn of the upper airway, lower airway. Carbon monoxide poisoning is kind of unique because carbon monoxide poisoning, this is where you breathe in car exhaust, okay? Carbon monoxide, if I put an O2 sat on my patient, it will show them at 100%. But my patient is showing confusion. My patient is showing bright red skin, and literally their face looks like a cherry with carbon monoxide poisoning. The reason my oxygen saturation shows that it's good is because carbon monoxide binds tighter than oxygen on to the hemoglobin. So all the O2 sat measures is what percentage of my red blood cells are filled up with something. We assume that it's oxygen because in most cases it will be oxygen. However, if my patient has been exposed to carbon dioxide, my O2 sat may show 100%, but when I do an actual ABG blood draw, it's going to show significantly less oxygen in the blood. And that's due to carbon monoxide being on the red blood cells instead of oxygen. So we're going to have restrictive effects. If I have a chest burn or a torso burn that has eschar on it, I'm not going to be able to take a big, deep breath. And so that can also start up a potential for developing compartment syndrome. So my GI tract is going to be messed up. My patient isn't going to be able to eat for a period of time, and I'll need to put in an NG tube to pull out all this acidic stomach fluids. If, depending on the area burned, I may need a Foley catheter put in to be able to measure clearly how much fluid is coming out to make sure that we're able to fight this hypovolemic shock. And the immune system will be altered due to the large amounts of burns and response that the body is demanding. People with burns cannot regulate their body temperature. A big part of regulating your body temperature is actually a direct result of the skin. So they aren't able to thermoregulate. Burn units, if you are somebody who's chronically cold, this would be your choice of area to work as a nurse because the burn unit is constantly at a higher temperature than other units at the hospital. So a burn unit will typically be at 75 to 80 degrees. There's different phases of burn injuries. There's an emergent phase, and this is at the point of injury until fluid resuscitation has been completed. So what this means is, this is the very first part. You are still doing the resuscitation of a burned patient at the hospital with fluid resuscitation over the first 24 hours. The acute or immediate phase, this is from the first time that they're able to urinate up until we get these wounds closed, okay? So that can be, depending on the burn size, a longer period of time. After the wounds are closed, we enter the rehabilitation phase until they are able to regain physical functioning and psychosocial adjustment to the burn and be able to cope with the injuries. So during the emergent phase, the goal is preventing any injury to the nurse, preventing any injury to the EMS provider, Stopping the burning. Okay, you want to get them out of the fire, to have the fire department pull the person out. Irrigate any kind of chemical burns with cool water. Okay, do not apply ice to a burn. The ice application directly after that tissue has already been damaged can further damage the tissue. So do not apply ice. You want to run cool water over the area. Now, frequently there's an old wives' tale that you will have heard to apply butter to a burn. No. If the tissue is heat damaged, applying butter to that burn is going to continue to cook that tissue. Okay? So you want to use cool water, not cold. You want to use cool water to immediately cool the skin. Okay? Do not apply dry 4x4s to the burn. You want it to be covered in saline. Okay? The 4x4s to be covered in saline. Make sure that your patient has ABCs intact, airway, breathing, circulation. Put oxygen on them and get several large bore IVs. So this is going to be an 18 gauge or larger, and that's so you can get as much fluid in them as quickly as you possibly can. You want to remove things that are restrictive. So for instance, if they still have clothing on, get that clothing. You don't want to just pull it off the areas that are burned. If the clothing is burned to the skin, you literally cut the part of clothing off that you can get off and then leave the other intact for a physician to potentially remove during surgery. So with this, you need to make sure you're doing a complete body systems analysis and getting an in-depth patient history as well. Figure out what was going on, what caused the type of burn, and any inhalation burn, since it directly affects the airway, takes precedence. So, with patients with other types of burns, like let's say an electrical burn, they may also have fall injuries as a result, and they could also potentially have cervical spinal injuries as a result of the jerking movements that happen with electrical burns. So a patient is transported to the emergency department. Depending upon the mechanism of the burn and the amount of burn tissue, they may actually bring a bird out, bring a helicopter out, and transport that patient directly to a burn facility. So the closest burn facilities that we have is Erlanger in Chattanooga. That's a burn facility. We also have Vanderbilt, which is in Nashville, burn facility. And then also UK Lexington is a burn facility. Now, for pediatric patients, Cincinnati Children's Hospital is one of the key burn facilities, and Vanderbilt Children's Hospital is also a burn facility. So, as we talked about, believe it was in the shock lecture, we talked about in hypovolemic shock, we can replace fluid 1 for 1 with, like, if we lose 1 pint of fluid, we can replace 1 pint of fluid to put back in to make up for it. If we are using normal saline, it's a 1-to-1 ratio, okay? But we talked about lactated ringers. It gives you more bang for your buck. It is a crystalloid, okay? But with lactated ringers, I can put in a pint of lactated ringers and it will make up for a quart of fluid that's lost, okay? So it doubles in the amount of fluid that it pulls back into the vasculature. So in a burn situation, you've lost a ton of fluid. Lactic ringers is what you're going to replace it with. Foley's going to be put in place. If we have burns to the mouth, or large scale burns, 20 to 25%. We're going to have to put in an NG tube and place it to suction to pull all the acid, help stop the patient from going into acidosis. We need to make sure that this person is continually monitored. If you're working within a burn unit, you will literally only have potentially one patient if it's severe, severe burns, or at max 3 patients. So it is truly an ICU type situation. Any patient with severe burns or any kind of electrical burns need to have EKG monitoring. Again, DC current causes asystole, AC current, alternating current causes development of VTach, VFib. You want to give good pain medications. IV pain meds are the only ones that should be administered during this phase. And often, family will have guilt about the burn, and so not know how to support the patient who's been burned. You need to prepare the family for what they're going to see before you bring family back to see this person. So, summary of the emergency phase. So, with this, you're going to need to have oxygen on, make sure their ABCs are intact, do frequent vital sign monitoring because these patients will compensate until they can't compensate anymore. With the amount of cells that are being damaged, we need to keep a close look at the potassium level. We want to make sure that they're not hyperkalemic as a result of the massive tissue injury. So monitor for fluid volume deficit, hypovolemia. We need to do strict I's and O's. Figure out the total extent of what has been burned and help them maintain their body temperature. That's thermoregulation. So other things we have to worry about. Patients will compensate as much as they can until they can't physiologically compensate anymore. So we'll often see acute respiratory failure. We'll see hypovolemic shock, can see lethal dysrhythmias, distributive shock. So as we talked about during the shock lecture, the burn is the first domino that causes hypovolemic shock to happen. So they can develop acute kidney injury due to lack of perfusion to the kidneys due to low blood pressure. Compartment syndrome. This is where their body is being bound by this eschar and it causes the development of compartment syndrome. They can't manage their own body temperature and their GI tract may completely stop. So with this, the small intestines and large intestine, you will not hear any bowel sounds, and that's called a paralytic ileus. So you've got to give the GI system time to rest and be able to heal prior to challenging it with food. So acute respiratory failure. This is very common with inhalation burns. Acute respiratory failure often creates stridor because the airway itself is injured. And if you hear stridor, that means that there is swelling within the upper respiratory tract. And that is a very dangerous sign for the patient. It's very ominous. You want to look for soot, black around the nares, burned nasal hairs. People with acute respiratory failure impending will be very hoarse. They'll often have burns of the face, neck, and chest as well. The alveoli can be damaged and can completely shut. So this results in pulmonary edema, bronchial edema, and secretions. This can throw your patient into heart failure. So your patient may require frequent deep suctioning to be able to get the fluid under control in the lungs. The lung itself can completely collapse. This is atelectasis. So what do we need to do as a nurse? We need to monitor their chest x-rays. We need to get frequent chest x-rays. So every day they'll be getting a chest x-ray. Their blood gases, we'll be monitoring their blood gases, doing serial blood gases every, if they're in the actively crashing, we'll be doing it every 5 minutes or so. If they are relatively stable, it could be every 6 hours or even every day. Also monitoring pulse oximeter, preparing for intubation, because if they can't breathe on their own, we have to breathe for them. And you've got to make sure that the inside of their lungs have already been damaged. So you want to make sure that you're using humidified oxygen for these patients. So for hypovolemic shock, plasma is the only thing that's going to ooze out of the burn, okay? We're going to be keeping the red blood cells, but plasma, the fluid, will ooze out of the burn. So fluid resuscitation, we want to keep the blood pressure. We don't want to get the blood pressure too high because that's going to create other systemic problems. We want to maintain the blood pressure in the low normal range. Okay, so somewhere around 100 systolic, 110 systolic, and then preferably above 60 diastolic. Greatest volume of leakage is going to be in the first 36 hours. The oozing peaks after 8 hours. And so after that point in time, you're continuing your fluid resuscitation for that whole time to replace that plasma that's being lost. So as you're losing the plasma, with this, the hematocrit is going to be unusually high. And that's because hematocrit is measured by volume within the fluid. So as you take away the fluid, your hematocrit will appear to be unusually high. And that's perfectly normal. So we said as cells die, they release potassium. And too much potassium causes peak T waves. Look at those T waves in V2 and in V3. Those are very peaked, okay? And so that is a result of too much potassium. So our patient will be placed on the EKG, and we'll also be monitoring them to make sure they're not having chest pain and make sure they're not actually having an infarct as a result of the burn. Now, as we start fluid resuscitation, we dilute this fluid down. So hypokalemia can occur afterwards. Now, potassium is the first thing that's going to get wonky, but eventually your sodium levels can get wonky as well. So you need to make sure your patient's not experiencing hyponatremia as we are diluting this fluid down as well. Distributive shock. So what will happen is as the vasculature opens up, fluids are going to leave the vascular space and go other places in the body, third spacing. So we're going to have swelling different places. And this causes problems with tissue perfusion and also too low of blood volume within the body. So we want to monitor the blood pressure, monitor the urine output, monitor the pulse, and monitor their kidney function with the creatinine. So we want to continue aggressive fluid resuscitation with lactated ringers, as we've talked about. The increasing their blood pressure helps to keep the kidney perfused and makes it less likely for the kidney to sustain any permanent damage as a result of the burn. So the kidney injury that can happen is due to myoglobin reaching the bloodstream, and this myoglobin gets stuck within the kidney. Okay, it's going to lower the GFR, it's going to lower your creatinine clearance. Go back and dust some cobwebs about what creatinine and creatinine clearance is. And it's also going to decrease your urinary output. So we will be doing frequent UAs to be able to assess the kidney function and what waste products are being removed from the body. But these will be drawn from the Foley because we're having to do strict monitoring of the eyes and nose. Compartment syndrome. So when we have eschar, or we have severe swelling, and there's only so much room that the body can swell. So this causes expansion and this fluid starts to accumulate and it starts to put pressure on the blood flow into the extremity, into the area. And as a result of that, impinging the blood flow coming into the area that's going to take away waste products, that's going to bring nutrition, that's going to bring oxygen into the area. If we don't fix it where waste products can get out and oxygen can get in, then the tissue will start to die. As the tissue starts to die, it sends toxins to other places in the body. So the way we fix this is through guided cuts, okay? And that will help to relieve the constriction. So, if we have eschar, then what we will see is cuts within the blackened tissue that will allow the tissue to expand. Now, eventually, we'll have to do skin grafts and cover those, but during the emergent time, the death by compartment syndrome is more significant than potential disfigurement from the cuts to allow tissue to expand. So this is called an eschar-otomy. So we're cutting into the eschar to relieve the constriction. We want to make sure after that we have patent pulses below the side of the cut, that we have capillary refill. And you may, if the blood pressure is so low, you may need a Doppler to be able to ascertain the pressure. If I have cut open tissue, do not apply the blood pressure cuff there. This is why we have thigh cuffs, is if we need to have if both arms have been injured in a certain accident. You want to elevate the burned extremities. That helps to increase venous return of the fluid back to the body, and it also helps to decrease swelling. Whenever we have a loss of pulse, you need to immediately report that because that means that the limb is under too much pressure and that we need to do something to help relieve that pressure. Eschar-otomy. So as you can see, this is a severe burn, and so we have cuts that are cutting it into different squares. If we did not have these cuts in place, this person would not be able to have their ribs move to when they inhale. So this is allowing the ribs to be able to move to ensure adequate oxygenation. It also is to prevent compartment syndrome. Okay, so this relieves the edema, gives the swelling a place to happen, and it helps to relieve the constricted muscle. So over time, we will have to replace this with skin grafts, but we have to have our patient stay alive until that time. These eschar-otomies, fasciotomies open up the tissue to allow swelling to happen, since you really cannot stop swelling from happening. Thermoregulation. So often you'll see somebody placed under an air blanket. So this is called a bear hugger. Now, way back when I was in school, I thought this was because it like maintained tight contact, like a bear hug, BEAR hug. No, turns out it's spelled BAIR hugger. The way I found this out was I had sent a page to one of the physicians and asked them for an order, if they could put in an order for a bear hugger for my patient. And of course, I spelled it BEAR, thinking that's what it was. Oh, I got ribbed about that for years. Okay. So that doc actually affectionately, he got a good laugh out of it, would come on the floor and call me bear hugger. And it's because I didn't know. So I'm stopping you from making that mistake. A bear hugger is actually spelled BAIR, and it is an air blanket. So you want to assess the core body temperature because any type of temperature thermoregulation problems puts this patient at higher risk for hypothermia. They can't control their own body temperature. And so the way that we assess the body temperature is by using a Foley catheter with a temperature sensor, and this monitors the core body temperature. Paralytic ileus, this is where the stomach stops working, the small intestines stop working, or the large intestines stop working. You will hear no bowel sounds if your patient has a paralytic ileus. So this is the result of inadequate tissue perfusion, and this changes because the tissues aren't being perfused. It changes the way the GI system works. So you want to monitor for increased bladder pressure. Make sure that your patient is able to pee. That compression from the bladder can press onto the bowels and stop them from working appropriately. Keep monitoring for sepsis, checking for lactates. Remember, we have to send them down on ice. And so we need to make sure that our patient has an NG tube in place and that we are actively decompressing the stomach and upper parts of the small intestine. You also want to monitor for GI bleeds because that can be something else that goes along with paralytic ileus. But as soon as you start noticing significant slowing of the bowel sounds, you need to immediately report this, especially if the patient doesn't have any bowel sounds. Special consideration with electrical burns. This is kind of like a gunshot. The entry burn is smaller than the exit burn. Okay. So the entry is where it's going in at, and you can plot the path that the electricity took by looking at the entry and exit burns. Okay. So remember, AC current can hold people, especially high voltage AC current working on the power poles, that kind of thing, can actually hold the patient to the electric current so they continue getting shocked. They have a high risk of dysrhythmias, vasculature's injured, and tissue. You may not realize the extent of the injury until later on. So you need to think of this as an internal burn, and it's kind of difficult to assess the damage. So immediately after an electrical burn, you need to continue providing respiratory support, making sure that they've got an adequate fluid and electrolyte balance, and that their kidneys are still working and their GI system still working. Prevent infection. Use wound care. Uh, do wound care frequently on the entrance and the exit wounds. Ensure that you're doing adequate pain management, and this state also increases the amount of glucose that your patient is using. So it's a hypermetabolic state. And you want to assess their positioning to make sure that they aren't going to develop contractures and have problems with movement as the burn is healing. So our goal is to restore fluid balance, prevent infection, make sure that they've got enough sugar to be able to undertake the healing process. Make sure that the skin integrity is protected as best you can, relieving pain and discomfort, and helping them move, even if this is going to be passive movement. Infection. You've damaged your skin. This is your first defense from any kind of bacteria, virus, or fungal infections. So, as a result of this being damaged, sepsis is a huge complication um, as you are healing from a burn injury. Burn units have to be very, very hypervigilant about germs for their patients. So, burn units are considered clean units because none of these patients have immune systems. So, they're not going to be putting patients with contagious illness in a burn unit for overflow. You're not gonna, there's no risk of having a COVID patient on that floor. It's a clean unit. So we'll be using both systemic and also topical antibiotics. And we want to keep the wounds covered as best we can with dry, clean dressings. Now, this is later on that we use dry because initially we want to use all moistened dressings with saline. Silvadene. Silvadene is silver sulfadizine. You'll notice in wound care, we have several products that actually have silver in them. Silver has some extra electrons and it likes to bond with other electrons. So what we've found is if we use silver in wounds, it has anti-infective properties. So we can use silver-based antibiotics, this Silvadene cream. Now, notice there's sulfur in it. So if my patient has a sulfur allergy, they should not be using Silvadene cream. So these will not penetrate the eschar, and it can cause hyponatremia and hypokalemia. So we want to do frequent monitoring of the CMP, complete metabolic profile, basic metabolic profile. Now, there's Silvadene actually has some very staunch supporters. However, not all studies support consistent use of Silvadene. So we have another topical antibiotic that we can use, mafenide acetate. Now, this will actually penetrate through the eschar. And think about it. If it is breaking down the eschar, it's going to be very, very painful. And so we may also see acidosis as a result of the tissues, the burned in tissue, the eschar, as a result of the eschar, some of it allowing this to penetrate through and being able to enter the blood supply. So, wound care, we want to apply topical ointments, apply dry dressings. If the wound gets oozy, nasty, we change it, even if it isn't our appropriate quote unquote time to change it. You want to always wrap from distal to proximal, okay? So we start far away and we wrap closer to the body. Wrap each individual finger or toe individually, and as dressings can stick to the wound, before you're doing wound care, you need to give the patient pain medicine because it's extremely painful. They will have very, very good pain medicine available to them for wound changes. And so be sure that you're pre-medicating them with some kind of pain medicine and to facilitate changing the dressing without ripping out skin that has become stuck to it, you want to consider moistening the dressing with sterile water. Hydrotherapy. This is where we put them in a huge bathtub and we are continually irrigating the patient with water, and this causes the dead skin to get broken and sloughed off, also gets rid of bacteria. We also use hydrotherapy within trauma units as well to be able to ensure we get all the gravel out of somebody's skin. This is very painful, as you can imagine, so you want to pre-medicate your patients with pain medicine before hydrotherapy and also cluster your care. Give them time after hydrotherapy to just be able to rest and relax. Hydrotherapy also loosens contractures and it assists in the range of motion. Contractures. This is where your limbs, your neck, different parts of your body can spasm. And as the body heals, it heals inappropriately. And shrinking happens of the collagen, and this causes contractures. So, contractures, I have seen them so tight that you can be physically pulling on that limb and it just will not budge. Okay. Um, and the way to prevent contractures is passive range of motion and making sure that we are putting them in hand positionings that are not going to promote the development of contractures. Okay. We want to make sure we're stretching the fingers completely out, not just putting their hand on like roller gauze. You want to make sure that they're continually having their limbs moved if they're not able to move themselves. Massages and moisturizers can help with contractures, but they are also very painful while it's happening. Skin grafts. This is often done early to reduce the risk of infection, to make it less likely that you're losing so much fluid, losing protein, and to help stabilize your electrolytes. This also helps to prevent contractures as well. Autografts. This is where, if you're not completely burned, they take your skin and shave it off. It literally, I'll put a link into the Momentum Shell. It looks like a cheese cutter, and it comes through, and the skin, the top layer of skin, is being pushed out through the top. So this is skin taken from a patient and put back on them. There's less risk for rejection that way. Now, we also can have cadaveric skin grafts. There are tissue banks that we can get skin from. We also can get skin from pigs, and that's called xenografts. Now, in other areas, they don't have skin banks. Let's say in Belize in Central America. They don't have the tissue banking that we have here in the United States. So they actually have used tilapia skin, and put that on the patient. And what will happen is the patient's normal skin will start to grow up under the tilapia, and they're able to save people's lives despite having less resources for advanced care, like in the United States. Hypermetabolism, the body is under a huge amount of stress. So, what happens is the patients need more nutrients, whether this be TPN, depending upon if their stomach's able to have any kind of nutrition placed in it. But nutrition needs to be started early because the body is demanding more nutrients and it will destroy its stores. This is hypercatabolism, and this creates problems with the cardiovascular system. So, we may also need to use anabolic steroids and sometimes beta blockers to help decrease this hypermetabolic syndrome. During rehabilitation phase is you start getting them ready for discharge as early as you possibly can. You want to focus on wound healing, psychosocial support, making sure that they have a positive self-image. There is potentially scarring from skin grafts and scarring from burns that happen. the patient may need to be preparing for reconstructive surgery as a way to help improve their appearance, and they may not be able to go back to the same job that they had before due to limitations that have been put on the patient as a result of the burn and the burn healing. Burn pain is one of the most severe types of pain. They really need frequent medications, especially when you're doing any kind of wound cleaning or dressing changes. So, types of burn pain, you need to have a baseline level of pain control and then pre-medicate whenever they're having any kind of procedures, and then have breakthrough medications that can be used for breakthrough pain. Okay. Now, if you're having frequent breakthrough pain, you may need to increase or contact the physician to increase the resting amounts of baseline medications. We want to keep them on the least amount of pain medications that we can to keep them out of pain, but with that, we don't want them completely schnockered from the pain medicine. So as their condition improves, we want to try to decrease the pain medications. Analgesics. So we're going to be using IV pain medicine only during emergent and acute phases. This is when we're doing the fluid resuscitation. Morphine. Morphine has that side effect of decreasing air hunger. So if a person is having difficulty expanding their chest, difficulty breathing, morphine is a good choice because it decreases that air hunger. We also can use fentanyl patches on patients with burn pain. Now, anxiety goes hand in hand with pain. Nobody wants to be in pain. If we can help decrease the anxiety, whether that be through distraction, whether that be through relaxation techniques, breathing, that will also decrease the amount of pain medications that the person requires. If a person is not able to sleep, their brain has waste products in it, and they are not able to cope with pain as well as they can if they have had a good night's sleep. So we may also need to give these patients sleep medications to be able to help them um, use less narcotics, use less pain medication with burns. Okay, you guys can watch this video later. If you have any questions about burns, please shoot me an email or we can talk about it next week. You guys stay warm. Thanks. Bye.
Girls in here.